Good afternoon. Thank you to the International College of Surgeons for inviting me to your convention. The presentation I'm about to give was actually recently given in Argentina, but now I'm happily presenting this for your 77th Congress. Thank you again for inviting me. I'm Dr. Henry Di Maano. I'll be presenting on unilateral biportal endoscopic spine surgery for Pott's disease. So just a few disclosures. I have no conflicts of interest to report. I practice out of small private hospitals. I started doing unilateral biportal endoscopy in 2019 after over a decade of doing mostly open and mini open spine fusion surgeries. I used to do fusion for about 9 out of every 10 patients that I had. But ever since I shifted to spine endoscopy, it's now the reverse. I am now saving patients from having to get fusion. So my advocacy is actually an inherited legacy from Dr. Ramon Gustilo. For those of you who don't know, he's a preeminent orthopedic surgeon who made his name with open fractures, with trauma, and with joint replacement. Unfortunately, he recently passed away in 2024. But his dream was to bring innovations and new technology to patients in particular who could not afford expensive surgery, to keep it simple and not do over-indicated surgery. And basically, he wanted to bring it to those who need it most, especially those who have no access to tertiary referral centers that are normally located in the more well-developed parts of our country, usually in the big cities. Okay, so let's go. When we talk about tuberculosis, we know that the Philippines has a very high burden of pulmonary tuberculosis. So we are all exposed. All sectors of population are affected by this particular disease. We know that about 10% of extrapulmonary TB will manifest in the skeletal system, and about half of this will be in the spine. Now, sadly, the risk factors for getting extrapulmonary TB as well as pulmonary TB are largely socioeconomic. We still treat tuberculosis using quadruple anticox treatment. But when the patients start manifesting with neurologic compression symptoms, we turn to surgery. Okay, typically, this surgical approach is an open procedure. I'd like to share a particular systematic review that recently came out from Romanianto et al. And it's very interesting because this particular systematic review looks at Pott's disease articles that have been published over the years. Okay, so we know that there's a propensity for orthopedic papers for Pott's disease. And probably the bias towards orthopedics is because of the fact that surgical treatment, in particular for Pott's disease, largely involves implants, instrumentation, fixation, and deformity correction. Okay, in the early part of our approach to the disease, the focus was largely on the medication, pharmacologic management, as well as the open techniques, open surgery that we used to do. But in recent years, in recent decades, because of better diagnostic technology, we are now able to detect the disease early and therefore start treatment early. And you can actually start introducing less invasive surgical techniques. Okay, here are a few scenarios, a few conditions that we deal with in Pott's disease. Number one, of course, is the infection itself. The bones develop osteomyelitis, develop an abscess. There's your bone infection over there in the vertebra. This is an psoas abscess, another psoas abscess over here. And it can grow large. And of course, the inflammation continues to eat through bone. When we see this in patients, of course, we start anti-TB drugs. And the idea is keep them on the drugs and let the drugs slowly control the infection. Okay, but then of course, during the course of this, there will be compression of either the spinal cord and or the nerve roots. If you can drain the abscess, that would be good because these abscesses will be irritating the nerve roots coming out of the spinal column. If there is continued infection, there will eventually be mechanical compromise. The bones of the spine will collapse to some extent. And of course, the more the infection, the more the collapse. And the more the collapse, that will add to your neurologic compromise. But of course, the response to this, the surgical response will be, okay, let's go in, decompress what is being compressed, and possibly debride the area, remove as much infected material as possible. So just to compare between pre-operative state and a year after surgery was done, so you can clearly see the extent of decompression in this particular vertebra. Okay, do we fixate? As I said, in orthopedics, there's a bias for doing the treatment and using implants like these pedicle screws and rods in order to stabilize what is already unstable. We'll have to use implants whenever there's massive instability. So this is basically fixation of an unstable segment. You bypass the unstable segment and you structurally support it if necessary. So now you have a patient with spine pain with neurologic symptoms, with imaging findings consistent of a lytic lesion, an inflammatory lytic lesion. Sometimes TB can manifest very benignly, like in this patient. Starts off with radiculopathy, and he was diagnosed with a slip disc. They thought the symptoms was coming from L5S1, but in reality, there was already a beginning abscess at L4, L5, and 3 months later, it basically blew as an outright infection. So now you can actually see the abscess and see the compression from here to here in just 3 months. You want to know, does the patient have mechanical back pain? Can he still stay upright? Can he walk? Can he sit? Or is the pain causing the patient to want to be lying supine all the time? You want to know if his pain is progressing together with the neurologic symptoms. You would want to know how the image looks like. Is there already bony collapse? Sometimes it's not just in one segment, but multiple segments are involved. Of course, you'll notice that there will be at some stage there will be compression of the neural canal elements. Okay, in this case, this is the spinal cord, and you can see that the infection is compressing on that. There will be gross deformity of the spine. Like I said, there's going to be kyphosis as the spine collapses. There could be non-surgical intervention for this, like putting in a brace, a full body brace like this, or you could, of course, resort to your open surgery with fixation using implants and bypass the area that is collapsing. As they progress, these will give you either radiculopathy or myelopathy, sensory and later on motor symptoms as the neural elements become compressed. They can hit the cervical spine. Mostly they commonly hit the thoracic spine or the thoracolumbar junction, and sometimes even the lower lumbar spine. So in these cases, you're going to decide you will probably need to decompress left to right, do a bilateral decompression, and make sure that all of these compressed areas are cleared. Okay. Sometimes if there's abscess, you might want to drain it out. That reduces the infectious focus, especially with abscesses this big. This will show up on your ultrasound. You can do a percutaneous ultrasound drainage of these under local anesthesia or with sedation. Okay. You have your patient with neurologic symptoms, symptoms of compression, but if you catch them early, maybe they don't have mechanical back pain or instability pain just yet. Good for you if you catch the patient this early. In most cases, however, we find patients with neurologic compression, and when they present, they already have bony collapse because the bones are being eaten. So they have mechanical back pain. Again, you want to decompress these patients in order to save the neurologic elements. And most likely, you will start thinking, maybe I need to put in implants to stabilize the collapsing part of the spine. Okay, again, screws and rods, and sometimes even cages that will provide structural support for areas that have been eaten away by infection. Okay. Now you will expect that this is going to be involve a large exposure, a large surgical wound. Expect that there will be a lot of blood loss because of the big exposure. There will be significant bone loss because now when you access this, you'll be clearing out abscess, clearing out bony fragments, dead bone possibly. You will end up with a big space like this, a big defect. In which case you will have to use fixation hardware, possibly a bony allograft or bony structural weight-bearing bone, or if not that, maybe a titanium cage filled with bone material, and of course your screws and rods that will hold the spine together. Okay, and the recovery is going to be very difficult for the patient. There's a lot of pain, high risk of infection. Okay, the patients are going to be debilitated for quite some time. So we go back to our components of Pott's disease. Okay, so you've started your drugs, you're keeping that, you're considering doing the decompression, or maybe you've already done it, and maybe because of the decompression that you've done, you need to add fixation and grafting. However, what if you could approach all these three components without having to create a big opening? Use only a minimally invasive technique. This would mean you would have less blood loss. Since you're not going to be excavating a lot of the spine, that would also mean that there will be less bone loss and you will be leaving more bone inside. If you can preserve stability of the spine by using a small approach, a minimally invasive approach, then maybe you don't destabilize the spine any further, especially if you catch the disease in its earlier state wherein there hasn't been much destabilization that's happening. So now you might actually be able to skip having to add fixation hardware to the spine. And of course, because of a minimally invasive approach, you expect faster recovery, relatively speaking, from the patient. Okay, this is open surgery, just an example. This is one of the surgeries I did in my earlier career. Open lumbar surgery, muscles all stripped, bone exposed. Of course, as I continued my spine practice, I later transitioned to smaller surgeries that take a sideward approach. So it's very important to preserve the multifidus muscle, the midline structures, ligaments and bone, and the facet joints, because those are structures that help stabilize the spine. Of course, when we talk about minimally invasive spine surgery or approaches, the device that comes to mind is a tubular retractor system, which was popularized in the 1990s. You will have this particular view. It's a very small view of the spine, and you will require an operative microscope for this. Just to give you a background on spine endoscopy, the percutaneous approach was actually popularized by American surgeon Dr. Parvis Cambin and independently by Dr. Sadahisa Hijikata. Technology of the scope, the design was perfected by another American surgeon, Dr. Anthony Young. Dr. Thomas Hoogland, a British surgeon, developed drills that could shave off bone. Okay, so now you can address both disc as well as facet arthropathy and other degenerative changes of the spine. It's a uniportal scope, just like this. It's a long scope. You approach it from the posterolateral side of the back instead of the traditional direct posterior approach. Okay, and of course, your instruments pass through that barrel, and the instruments are rather long. One of the drawbacks of uniportal surgery is that the equipment is expensive, and so adoption of this technology proved somewhat slow. Daniel De Antoni actually was the first who ventured doing biportal surgery. He did this in the late 80s, going to the 90s. He did a case series of these and actually showed that this was viable technology. Later on, one of the Korean forefathers of biportal endoscopy, Dr. Jin Wah-hyum, actually went and trained under or learned from Dr. De Antoni and then brought it back to Korea. So this core group of South Korean surgeons are the people who pioneered biportal endoscopic surgery in South Korea. And they started developing it around the turn of the millennium, around 2001. As a matter of fact, these four people, Dr. Hyo, Dr. Son, Dr. Yum, and Dr. Park, are the sort of forefathers of this technology in South Korea. To be quite literal, they wrote the book on it, on this particular topic. And this is the first edition of the book. I am happy to say that my training actually was luckily under that of Dr. Cholmung Park. So I've actually trained with him over the years, beginning in 2019 up until 2025. Okay, and now in 2025, there is a second edition to the book, which I'm also happy to say I am part of and proud of. So the knowledge has exponentially expanded over the years, and it's very exciting. This is a picture of a discectomy procedure. This is the basic procedure that everyone needs to learn when you're doing spine endoscopy. You start with this. This is lumbar discectomy. Okay, and it's essentially similar to your laparoscopic technique. Okay, this is now a patient with Pott's disease, this patient over here. So her spine, her thoracic spine was being eaten away. So what I had to do was decompress it. And since she could afford getting implants, I said we need to bypass the collapsing area and I need to put screws and rods in order to prevent this from further collapsing. But the take home here is that the technique, biportal endoscopy, provides a very good decompression. Okay, so that's this patient. This is another patient with the L5 collapse, L4, L5 collapse. Now the take-home message here is that both of them got fixation, but I put hardware in, and the next day after surgery, they could already tolerate being upright, walking or sitting, and of course, there's a very significant return of neurologic activity. This patient had weakness already and could not actually do this before surgery, but after decompression she started moving her legs, her thighs, and could now sit without pain. Again, patients that usually come to us already have neurologic compression because of the infection, and at the same time, lysis of the structures of the spine and structural collapse. A lot of patients actually would decline getting instrumentation done. They would outright refuse to actually have implants brought in. And the main reason for this, the most common reason, is the implants are expensive. Here in the Philippines, patients have to buy their own implants, even if they're getting the treatment done in a government hospital, in a charity hospital. The dilemma of the surgeon now is, do I delay the surgery because the patient doesn't have money for the implants? Do I wait for them to raise funds before I do the surgery? And during that time, the neurologic elements just get compressed and possibly get permanently damaged. So how do you treat promptly if the patient cannot afford having implants also thrown into the mix? Well, this is where endoscopic surgery can actually give a lot of usefulness, because by using a very small surgical footprint, you can actually do spine surgery that, as I said, does not add to the instability of the spine or does not create any instability. And therefore, you might just be able to uh, basically either defer using implants or may outright totally forego the use of implants for these patients. So this is a short animation that shows you how we do biportal endoscopic spine surgery. So as it says biportal, you make two holes. We create our space here using saline solution being pumped in. We create more space by removing bone that can be sacrificed, particularly the lamina. And the most important thing here is that you have the capability of decompressing both sides. You can burr bone the opposite and you can burr bone here, take out the ligamentum flavum, and still preserve the facet joints. And then after that, you can decompress the area of the disc if you need to. So the spine doesn't become unstable, but you get maximum decompression just the same. So again, Pott's disease, patient with Pott's disease undergoing bilateral decompression. This is the flavum. That's the bone that I'm drilling over there to create more space. Okay, more bone being drilled to create more space. That's flavum over there detaching. Some of the flavum is adherent. One of the characteristics of Pott's disease is that there's a lot of inflammation inside and possibly adhesion. Doing a discectomy now in order to further create more space. And this is your dural sac that now is very much decompressed from left to right, top to bottom. So that is what the technique can give you, and it only requires two small holes with minimal blood loss and with faster recovery following surgery. So, what can we see now in this particular approach to Pott's disease? Well, definitely early diagnosis is an advantage. Possibly you can start using minimally invasive approaches instead of a full open approach. Okay. Instrumentation, of course, is very useful, but as I said, if the patient cannot afford it, should you wait until the patient can afford it, or do you decompress promptly in order to save the nerve structures? Okay, again, being minimally invasive means preserving stability or not adding to instability. And in particular, the least invasive of all, of course, at this point is endoscopic approach. Basically, we make use of an approach called ULBD, unilateral laminotomy with bilateral decompression. And again, you can do the surgery without instrumentation if the situation forces you to take that particular choice or route. The nice thing with this technology, it's very adaptable to low resource settings. Typically, the hospital or your OR will need to have an endoscopic tower. This costs millions. So, what can we do to lower the cost? Make use of a portable scope system that simply attaches to a TV or a computer. And it is very easy to purchase this. Okay, the scopes are the same. These are the same scopes that we use for knee and shoulder. Okay, but you attach them to a system like this. Okay, speaking of the scopes, well, one of the things I learned from Dr. Park when I trained for biportal endoscopy is using a plastic trocar. This is designed by Dr. Park, but this is not available in the open market. They don't sell this. What can I possibly do to replace this or to duplicate its function? Your laparoscopic disposable plastic trocars, 5 millimeter, can actually be machined or trimmed in order to duplicate the function of this one. Standard scope sheath for your rigid scope. Okay. But of course, this thing doesn't have a retractor tip. It's sometimes it's more useful if it does have a retractor tip. So what can you do? Well, in order to innovate on this, I just basically took the laparoscopic trocar, attached it to a drinking straw, which I machined. I basically contoured the tip to this and to this. So those are plastic trocars attached to your drinking straw. This is a standard arthroscopic burr or drill, and this is a diamond burr or drill used in neurosurgery. We use this in arthroscopy, and of course, we can use it for spine. It comes with a detachable, disposable tip. Okay, but these machines they cost millions in order for your hospital to have this. So if you don't have this and you still want to be able to do this particular technique, what can you do? You can take the tip, cut it, fit it to a hand drill, and it works just the same. As long as you can rotate the drill bit and you can preserve the sheath, the protector, the guard, you can actually do your surgery like so. And one of the most useful things, of course, is a radiofrequency probe or radiofrequency ablator, which is again very expensive. So what can you do in order to duplicate the function? Well, the bipolar probes that we use for cautery in open spine surgery can be fixed in such a way that they function basically as endoscopic cautery probes. So you have this whole complement of instruments that have been retrofitted and can now be used for this particular type of surgery, even though they were originally intended for some other type of surgery. And the late Professor Clayton Christensen, the guy who described disruptive innovation or disruptive technology. You basically take old or existing technology and find a way to recombine them or retrofit them and apply them to different problems that initially they were not intended to address. You create technology that can turn something complicated and expensive into something affordable and simple. So the nice thing about biportal endoscopy is you can take all your instruments, put it in a suitcase, and travel anywhere, and you can do the surgery. You're ready to go. You're ready to suit up. You're ready to rock and roll. Okay, we've of course seen a growing number of papers of articles that show that there is comparable efficacy with this approach when treating spinal tuberculosis or Pott's disease. The technology can be combined or used singly if you want that. Okay, and it's effective. You can do a good decompression and save the patient from needing fixation. Or even if you are going to use fixation, it's also okay. There's no problem with that. Okay, the complication rates are comparable to existing technology. Actually, they're somewhat better with regards to the wound aspect because now this is minimally invasive and you have a small wound. Again, as Professor Clayton Christensen said with regards to medical disruptive technology, the whole idea is to take uh, existing technology, apply it to a new situation or to new challenges. Let the technology trickle down to places where higher end devices or higher end technologies cannot be afforded. Give it to those who are willing to use this technology in order to serve a segment of the population which cannot afford expensive treatments or expensive approaches. So we're hoping to slowly shift from having to do open surgeries, especially big open surgeries, or surgeries that involve fusion, like even small surgeries that involve fusion. If we can shift away from that and then slowly adapt the more minimally invasive techniques, which give you this result, then hopefully we can reconsider our stance on it and truly embrace this technology. Now, as Dr. Gustillo advocated, his idea was that technology and treatment should be something that maintains the efficacy, maintains the quality, and yet is affordable or within reach of the patients. Because his idea is, if the patients can't afford it, then even if it's good technology, what use is it if it only serves a very small portion of your population? If you have the time to watch his video documentary in YouTube, you can look for the DOST channel on YouTube and look for axis knee replacement. Okay, so with that, thank you very much for your attention and very good day and more power to the International College of Surgeons. Thank you very much again for inviting me, and I hope this has been eye-opening for you. Again, thank you very much and good afternoon.